Hello, my name is Erin Moran, and I am the Clinic Partnership Manager here at the MAVEN Project. Thank you all for joining us today, and thank you to our friends at Manic Community Health Center for hosting today's session, Dementia Evaluation and Treatment with Dr. Richard Mesher. And with that, we can begin.
Hello, everybody. Thanks for attending. My name is Rich Mesher. I'm a retired neurologist out here in the Seattle area, and it's my pleasure to give this talk today. I hope you have questions at the end that we can go over. So we're going to talk about the evaluation and treatment of dementia, as you know. I have no disclosures to make. And as Erin said, this talk qualifies for a 1 hour of CME. So this is the goals of our talk, the purpose of our objectives of our talk. We're going to diagnose dementia, including what you do in the clinic as far as testing and evaluation. And we'll talk a bit about the currently available treatments for Alzheimer's disease, and we're going to focus a lot actually on Alzheimer's disease. I'll talk about the other types of dementia, but we're going to focus on Alzheimer's. And then lastly, I'm going to go over with you a very hot topic, which I think is going to become increasingly relevant, which is the new treatment for Alzheimer's disease, targeting the protein amyloid deposition in the brain. And we'll go over this in quite a bit of detail because I think this is going to be something that's going to be very relevant in the coming years. Just to review, cognition involves various domains. There's executive function, which is localized into the frontal lobes. These are things like multitasking or puzzling through problems. There's obviously memory, which is localized in the inner portion of the temporal lobes and in a specific structure called the hippocampus. This is very relevant to Alzheimer's disease, as you'll see. There's language function, usually in the left hemisphere, can be in the right hemisphere in left-handed people. And then there's visual spatial tasks, which are located in the parietal areas and the occipital areas. So these are all various cognitive functions that can be and often are affected by dementia. So just a little neuroanatomy, the inner aspect of the temporal lobe is where that hippocampus is located. And you can see that. I don't know if I can, yeah, there's my cursor. Hopefully you can see that. But this is what we're talking about right here, the mesial temporal lobe, where new memories are formed and often where the Alzheimer's pathology begins. So what is dementia? Well, it's impairment in intellectual function involving more than one cognitive domain. So not just memory trouble, but other problems with language, visual, spatial, executive function. The impairment is such that it does interfere with a patient's ability to function socially or at work. And it represents a decline from a previous level. It's not a static brain problem. It's a progressive brain dysfunction. And it also is not explained by an acute problem with the brain, delirium, or by major psychiatric disease. Some of you may have heard of this MCI, mild cognitive impairment. This is a term that's used when the patient has really problems in one area. Typically, in the early Alzheimer's situation, it's memory, forming new memories, but other functions remain intact. The patient can still function pretty well, but their short-term memory is declining. When the memory is involved, this is called amnestic mild cognitive impairment. And basically, it's the beginning of Alzheimer's disease. So every year, there's a fairly high rate of conversion to dementia, meaning other domains get involved. This is a slide to show that there are other types of dementias. I'm not going to get into a lot of the other ones. Alzheimer's disease is the largest share of dementia in older folks. Vascular dementia is fairly common, and some people have mixed vascular and Alzheimer's. So those three groups are 3/4 of the dementias. There are the other ones, as I mentioned, Lewy body dementia, frontotemporal dementia, Parkinson's dementia. We're not going to talk about those too much today. So Alzheimer's disease, let's focus on that. It's the commonest neurodegenerative and dementing disease, as I mentioned. Interestingly, the older you get, the higher the chance you have to have Alzheimer's disease, and people older than 90 have a 50% chance of having Alzheimer's dementia. So the risk factors, as I mentioned, age is a huge risk factor. The older you get, the higher your risk. If you are displaying mild cognitive impairment, that's a big risk factor, as I said. There's also this marker, this biomarker, ApoE, which is a lipoprotein, and a certain genetic form of this, it's called ApoE4, really increases your risk of eventually developing Alzheimer's disease. The reason for that is not clear, but this can be tested for if appropriate. It's certainly not something you test routinely. Also, if you have a family history and a first-degree relative, especially young onset, that's a big a risk factor. Young onset defined as less than 65. Vascular disease is a risk factor. Diabetes, heart disease, etc. The vascular risk factors are something we can work on. And there are uncommon genes that cause early onset disease, sometimes autosomal dominant. Not very common, however. So this slide just shows where the pathology begins. It begins in the inside of the temporal lobe in the hippocampus and then gradually spreads. As it spreads, there's cell loss and brain atrophy. The ventricles in the brain dilate. The sulci widen. And this is the sort of gross neuroanatomic correlate. Atrophy of the brain on a MRI or CT per se does not necessarily mean the patient has dementia. Some people have atrophy to a mild to moderate degree and are cognitively fine. So it's a non-specific finding on a scan if you get that report. So how does Alzheimer's disease present? It's commonly that the patient is brought to medical attention by a spouse or family member or a friend who comes in and says they're repeating themselves, asking the same question over and over again, forgetting something that they were told 5 minutes ago. Sometimes the patients either don't really realize this, they lack insight, or sometimes there's some element of denial. The old rule of thumb is when the patient comes in and complains of memory trouble, it's probably not a big problem, but when the family brings them in and says the memory's bad, then it is a big problem. Like all rules of thumb, there can be exceptions. So, as I mentioned already, short-term memory is the first thing that becomes symptomatic. Loss of orientation, patient goes on a trip and has trouble orienting themselves. The Alzheimer's disease decline is usually fairly smooth without dramatic short-term fluctuations. That that certainly can be, if there's an acute medical illness, someone can decline pretty rapidly, but hopefully temporarily. And then gradually, as I mentioned, the other domains become involved over time, over years. There's a lot of psychiatric issues that Alzheimer's patients face that can be treated. Depression, anxiety. Some patients are irritable and hostile, others are more apathetic. There, of course, can be delusional thinking, hallucinations, problems with sleep. You're all probably familiar with sundowning, which is agitation at night. These are all behavioral problems that we can try to help with in terms of helping the caregivers. So what do we do in the clinic to evaluate? Well, the history is really very critical, and obviously a close informant is needed, and you want to see if this is an acute problem, subacute, or very gradual and getting gradually worse. You want to know if there's any other neurologic symptoms. And then you want to ask questions about the other domains, executive function, uh, visual spatial problems. Are they getting in car accidents and scraping up the car all the time? Those kinds of things, or disorientation. And is the patient able to function? Are they having trouble doing things around the house, operating the remote control for the TV or the microwave? Are their hobbies affected? If they're working, has there been complaints in the workplace? So these are all important historical features. And as you're kind of evaluating them, you want to know if they've had neurologic problems, head trauma, strokes, what medical problems they have. Education, higher educated people supposedly have some resilience in terms of developing dementia, but that certainly doesn't always hold up. Is there a family history that's remarkable? Have they been using alcohol or abusing drugs? And then medication review is really important, always in this setting. And so what we're trying to do here is look at things that we can modify and treat if possible. This is a busy slide. I apologize for it, but it really just kind of points out you want to look at the rate of decline, make sure it's not delirium. Uh, as I mentioned, look at drug and alcohol use, evaluate for severe depression. And then we do some testing to rule out medical conditions, thyroid disease, B12 deficiency, if appropriate, an RPR. Obstructive sleep apnea is a good thing to look at if the patient appears to be at risk for that. That certainly can have cognitive problems if severe. So it requires a good look at the history and all of the general medical issues. And that includes a neurologic exam. Is there anything focal? Does the patient have a hemiparesis? Do they look Parkinsonian? Um, Cognitive testing is really part of the eval. It can be kind of daunting doing cognitive testing when you are pressed for time in clinic. I understand this completely. Um, there are these standardized tests you're familiar with, the mini mental status exam and the Montreal Cognitive Assessment, MOCA, which is widely used. I would draw your attention to this little screening test called a mini cog. Um, This involves a draw clock test, which I'll show you in a minute, and then 3-word recall. This is a pretty good test, pretty sensitive. And if the patient flies through this, you're probably in good shape. If they have trouble, that would prompt you to maybe schedule them to come back and do a Montreal cognitive assessment, or if you have staff that can do that testing, move on to that. But the mini cog is very quick and does include part of this. This is the MOCA, the full MOCA, which takes 15-20 minutes to do. Very hard to do in the setting of a clinic visit unless you've scheduled for it. But this is a draw a clock test. You just draw a circle, put a dot in the middle, and tell the patient to fill in the numbers. They should be able to fill in the numbers easily. Usually they put in 12, 3, 6, 9 first and then fill in the other ones. But as soon as people get into early Alzheimer's, they have trouble with this test. And you ask them to fill in the hands, say put in the hands to say 230, and they can't do that. The numbers are out of the quadrant that they should be in. So very useful test, very quick to do. Draw clock test. Treatable causes, unfortunately, when the history is typical for Alzheimer's disease, we don't usually find another diagnosis, but we have to think about it, particularly if the rate of progression is subacute. Subdural hematomas can present with cognitive change. Chronic subdural hematomas are common in older folks, even with minimal head trauma. And we screen for thyroid disease, B12 deficiency. Again, severe sleep apnea can be very relevant. Severe psychiatric problems can be relevant. Obviously, alcohol abuse can lead to cognitive decline if it's severe and chronic. And then, as I mentioned, look at their meds. Are they on chronic benzodiazepines? The elderly persons are very sensitive to these meds, opioids, anticholinergics, even Benadryl, due to its anticholinergic side effect, can have some effect on cognition. But bladder drugs, such as oxybutynin, tricyclics, neuroleptics, people end up on neuroleptics as a sleeping pill. Variety of medications. So the medication list is really important to check because this could be adding to the problem in most cases, not primarily causing it, although it could, but certainly could be adding to the problem. So what do you do as far as a workup? There is no exact panel for typical dementia age, older folks greater than 65, B12, thyroid, and brain imaging. CT is okay. You get more information on vascular disease from an MRI, but you can certainly exclude a subdural hematoma or large tumor. Neuropsychological testing is expensive, tedious, not necessary in many cases. If you're dealing with a younger, higher functioning person, then you might need it. Someone in their 50s, for instance. And then there are these advanced imaging studies, PET scans, which generally aren't employed clinically, at least widespread at this point, although this may change. This PET scan that looks for amyloid in the brain is probably being utilized more and more, as I'll get to in a minute. So it's certainly not typical to do it. I think the red flag here is if you have a younger patient or a rapid atypical course, the workup should be tiered to look carefully at other treatable causes. You notice LP is not on here, but if it's a rapid progressive change in cognition, an LP might be needed, for instance. So why do we look? Because there can occasionally be treatable causes, or at least things we can affect. There are some symptomatic treatments for Alzheimer's disease. And also, as I'm going to get into in a minute, there are some new monoclonal antibody treatments for Alzheimer's disease that are actually FDA approved. But importantly, the patients and their families, they want to know and understand what's going on. It helps with long-term planning. Some patients might want to get involved in research studies, and some families might want to get in support groups. So I think it's very important to make an accurate diagnosis and counsel the patient and the family. It's hard to counsel the patient. The term Alzheimer's disease is very scary. I think it's certainly reasonable to say you may have early dementia, could turn into Alzheimer's disease. We don't have that specific answer at the moment. We'll see how things go. This is where the art of counseling comes in. I was always hesitant to be too ironclad about it with the patient because it can cause a lot of anxiety, and that can be a huge problem. So what can we do in a public health sense to reduce Alzheimer's disease in the older population? Well, there's clear data that indicate that managing cardiovascular risk factors that you're all familiar with can help, because some patients have mixed dementia from vascular disease and Alzheimer's. So cardiovascular risk factors are really important to treat aggressively. And there is some evidence actually that regular exercise, a Mediterranean diet, and keeping cognitively active as you get older is helpful. Interestingly, doing puzzles on the internet probably don't help, but participating in social activities such as playing bridge, book clubs, this may reduce the risk of developing dementia in older folks. We've had these drugs now for a long time. They don't, unfortunately, do very much. I hate to say it, but it's true. There's the cholinesterase inhibitors, which increase acetylcholine in the brain. Aricept is the brand name. Donepezil is the generic. There's also rivastigmine and galantamine. Might help with some apathy and mood. They do not help memory, unfortunately. The other class of drug, memantine, probably helps agitation, makes people in the moderate to severe categories of Alzheimer's calmer. As I said, review their other medications. Make sure there isn't something making things worse. Treat their depression. It's okay to use low-dose antidepressants, both for depression and anxiety, and treat sleep apnea if it's present. So I'm now going to go, excuse me. I'm now going to go into the amyloid hypothesis of Alzheimer's disease. I'm going to go into this in some detail because it's really important that you understand this, because it's really going to become more and more relevant. Patients and families are going to ask you about it in the coming years, because there's been really kind of a sea change in the way we approach Alzheimer's, and it's evolving rapidly. So the amyloid hypothesis as the cause of Alzheimer's has been around for a quarter of a century at least. And that's because on neuropathology, there's these deposits of this amyloid protein in the brains of patients with Alzheimer's disease. It's a pathologic hallmark. This slide, excuse me, shows amyloid deposition. It also shows this thing called a neurofibrillary tangle, which is basically a dead neuron. And this is composed mainly of a protein called tau, T-A-U, which you'll possibly hear about because there are now tests for both tau and amyloid in the spinal fluid and actually in the blood. And also we can do PET scans for both. So these two proteins are the pathologic hallmarks of Alzheimer's disease, amyloid and neurofibrillary tangles composed of tau protein. So this is a PET scan where the ligand attaches to amyloid in the brain. And you can see as you move left to right that when patients have a lot of amyloid deposition, the PET scan is very abnormal, bright orange, and shows the amyloid deposition in the brain. So what is this hypothesis? Well, there's this amyloid precursor protein. It's a transmembrane protein associated with neuronal development and other functions. And normally a portion of this amyloid beta is cleaved by enzymes, and then the amyloid beta is degraded and removed extracellularly. So here's the amyloid precursor protein. And then the enzymes cleave it. But as a result of aging, genetic factors, and also things we probably don't understand, the ability to degrade the amyloid beta diminishes, and the peptides accumulate in the brain, forming these amyloid plaques. And the theory is these plaques are toxic to neurons, leading to neuronal death, brain atrophy, and dementia. So this is a cartoon version of the beta amyloid plaque. That the beta amyloid has not been removed as it normally would be, and it becomes deposited in the brain and felt to be toxic. So over the years, this has been the topic of multiple attempts to get the amyloid out of the brain. There have been vaccines, various ways to get the amyloid out. Most of these attempts were failures. The studies were negative. And the truth is, even today, the exact role of beta amyloid as a primary causative agent of Alzheimer's disease is still controversial. But there are also all kinds of other theories. I'm not going to go into this, but there's many, many other theories of why neuronal death occurs in Alzheimer's disease. And again, the whole issue is still hotly debated. But in recent years, monoclonal antibodies have been developed to basically attach onto the amyloid protein. The immune system then removes it. The goal was to see if it would slow or arrest cell death and dementia. As I mentioned, many other trials had been negative until recent years. But there are now two drugs approved by the FDA that are this type of drug, a monoclonal antibody. This one, aducanumab, was approved back in 2021. This was very controversial approval because it didn't show clinical benefit. It just helped the PET scans. I don't think this drug's really being used at this point. The second drug, however, lecanemab, was approved last year, and it did show some reduction in cognitive decline on a dementia rating scale. The correlation with clinical benefit was somewhat foggy, but the FDA approved it, and lecanemab is being administered across the country in usually centers, academic centers, areas where there's specific dementia clinics. So this drug is now in clinical use. There is a third drug, donanemab, which everyone thought was going to be approved a couple weeks ago, but the FDA wanted some more data. This drug actually did show clinical benefit. 47% of those who received the drug compared to 29% showed no signs of cognitive decline after 1 year. So I think the FDA is probably going to approve it. All of these drugs are dramatically effective in making the PET scans look better, removing the amyloid. So what are the pros and cons of this? Well, this may be the first disease-modifying therapy for Alzheimer's disease. Very important if it is. And I think there's a lot of enthusiasm in the neurologic world for this. However, it's expensive. It requires infusions, either Q2 or Q4 weeks. And you have to do follow-up MRIs. And then there are problems in the brain from removing the amyloid. These are called amyloid-related imaging abnormalities, and they're small hemorrhages. There can be edema, as you see on this MRI. There's whitish areas in the temporal lobes. This is edema associated with the amyloid removal. Most of these imaging abnormalities are not this severe. They don't produce a lot of symptoms. The infusions can be held and then resumed. So it's not a huge impairment to administering these drugs, but in some individuals it is. And so the real question is, will this benefit persist? And will this really alter the curve long-term of Alzheimer's disease? And we just don't know yet about that. So what's the future of these anti-amyloid treatments? Well, this year there was a publication in Nature Medicine which showed that you can test in the blood for the abnormal amyloid pattern and also for elevated tau protein. So it may be that now there are screening blood tests that would indicate a patient would be at high risk for eventually getting Alzheimer's disease, particularly with a strong family history. Or if you test for that ApoE4 allele, and they have that. So in the future, are we going to be routinely testing for this sort of thing? Are we going to try to identify people who are pre-symptomatic and refer them for anti-amyloid treatment? Well, I don't know the answer to those questions, but I think this is a real possibility. So that's all I had to say. I finished pretty early. I certainly would be happy to take any questions.
Thank you thank you so much, Dr. Mesher. We do have 2 questions in the chat already. The first question is, wondering about home conservative treatments like vitamins or games that might help.
Yeah, I mean, I certainly have no objection to giving people a multivitamin, but there's no data that any specific vitamin therapies are helpful unless the patient's B12 deficient, which obviously can be determined on blood work. Again, I think the data with cognitive activity is more in the shown to be most helpful in the social sense. So I think playing a game at home with someone else or 3 people playing cards, playing bridge, maybe playing board games. It seems to be the social interaction that is important in this context.
Thank you. The next question is, any guidance guidance on when or how to discuss driving?
Oh, that's just a great question. So the data show that patients with moderate Alzheimer's disease have the same rate of accidents as inebriated people who've been drinking. So this is a big deal. And I think it varies so much state to state. Um, I think you have to rely on the family as to whether the patient is having trouble driving. And certainly, I think if they are having full-blown dementia in with multiple domains involved, their draw clock test is bad. You can imagine how that might translate into recognizing traffic signs, traffic signals. And I think you just have to say, at this point, I'm afraid you can't drive anymore. It's just too dangerous. And I think it has to be a conversation with the family present. Unfortunately, the patient's not going to remember what you said in many cases. So the family has to hear it. And also, sometimes you just write it down and give it to the patient so the family can show them this. Um, you can recommend, if the patient's very resistant, you can recommend a driving assessment. An occupational therapist in many places can do a driving assessment. In some states, you can recommend to the Department of Licensing that the patient have to undergo a driving test. Really depends on your state and what the regulations are. Some states you're not supposed to report things like this. But I think it's really important to address, and I think you have to rely on the family, uh, but also rely on your clinical assessment. If they're in uh, moderate stage of Alzheimer's, they're going to have trouble driving. And I think the topic needs to be raised.
Thank you so much. The next question is, what is the natural history of Alzheimer's in terms of duration to provide some guidance to family for their planning purposes?
The average length from time of diagnosis to death from whatever cause. A lot of people die with Alzheimer's, not from it. Certainly, people die of the complications, late Alzheimer's, late stage Alzheimer's. People are immobile. They have swallowing trouble. They get aspiration pneumonia is a very, very common way that people die. But the time of from diagnosis to death, it averages about 8 years. Uh, it's highly variable. And there are people that live way beyond 8 years and are quite vigorously healthy, but severely demented. So I think that you can give them that sort of time frame, but ultimately it's very hard to predict.
Thank you. The next question is, over the decades, have you seen a role of external environmental concerns that have impacted population risk for Alzheimer's related to increase in numbers or earlier onset diagnosis, as in concern for exposure to heavy metals?
I don't have a good question for that. I think that I can tell you this, that at the beginning of my career back in the late in about 1980, Alzheimer's disease was felt to be not very common. And I think it's just because we used to just accept that people were becoming cognitively impaired as they were old. It was sort of normal aging. Well, he's becoming senile. And I remember uh, when my father actually had Alzheimer's disease, and he came down with it in the early 80s. And ironically, I was a neurology resident at the time, and it was just not that well recognized by the medical community or by the general population. So I think over the decades, it's become very well recognized, and I think that's why we uh, see it so much. Is we now recognize that even in the old, uh, it's a disease. It's not just a normal aging. I don't really know of any data about heavy metals per se causing an increased incidence.
Okay, thank you. The next question is, has there been evidence that earlier treatment with antibody-based drugs is better? That seems to be the implication of your last few slides, including the screening issue.
Great question. So those studies that got those two drugs through the FDA, the patients had to either have mild cognitive amnestic impairment, early Alzheimer's with just memory trouble, or early dementia, meaning, they were still fairly good and fairly able to function, not in the moderate stages of dementia. So there are studies going on now in usually mainly out of the United States where they're trying to identify people pre-symptomatically. And I think the hope in the theory is, yes, if you get rid of that amyloid before there's enough cell death, maybe you can ward off dementia. And as I said, we now may have blood tests. And so I think that there's going to be a lot of information about this coming out in the coming years. And studies looking at treating high-risk people with amyloid in their brain, but they're cognitively normal. And does this help? And this is for sure coming, and we'll just have to watch for it.
Thank you. The next question is hippocampus size a constant in the diagnosis of AD or dementia in general? Is decrease in size predictive or concurrent with degree of dementia?
That's a good question. You get MRI reports and they will do measurements of the hippocampus, volumetric measurements. I think if you have severe hippocampal atrophy, that's a very bad sign and highly correlated with memory problems and probably Alzheimer's. Less severe hippocampal atrophy, I think, is really hard to hang your hat on as to whether that predicts it or not at this point. As I said, there are people who have pretty significant brain atrophy, including the hippocampus, who are cognitively normal. So I don't think you can diagnose it, Alzheimer's disease, from an MRI based just on hippocampal atrophy, but if everything else points to it and the hippocampus is severely atrophied, it's a confirmatory test. I hope I answered your question.
Thank you. Are there differences in prevalence related to race or ethnicity?
Yes, yeah, I think that I can't quote you numbers, I'm sorry, off the top of my head, but I think having, for instance, uncontrolled hypertension is a definite risk factor, which occurs in underserved populations, certain ethnic groups more than others. I don't think the ethnic differences are that important to consider in the individual patient. I do think the studies really need to include people of different ethnic backgrounds to show applicability across the population, the medication studies, the anti-amyloid therapies. I'm not sure it helps clinically much with the evaluation of an individual patient. And I can't quote you numbers, I'm sorry.
Thank you. Are there any other questions? We still have time, so please feel free to submit them into the Q&A, the chat, or feel free to raise your hand and I can unmute you. Yep, we have a raised hand. Okay, you can go ahead and unmute.
Can you hear me?
Yes, we can hear
Okay.
you.
Sorry about the fixation about the hippocampus. It's like something I ran across a little while ago. Are there any other conditions that can cause significant shrinkage of the hippocampus? And I can give an example. Somebody who had COVID and had a prolonged, over 1 year, his 1 year of very severe depression refractory to treatments, including ECT and ketamine. And eventually seemed to get better. And he did have an MRI, which showed a shrinkage of the hippocampus to around, by more than 20%. And he was having some trouble with some memory, and he's about 60 years old, but functioning otherwise well, with the exception of the anxiety and still residual depression. So that's why I was asking about it. Any with what anything about that, any experience with this?
I think 20%, I wouldn't, I think it's non-specific.
It is still non-specific. Okay.
Yeah, I really do. I mean, I think when you get a report says the hippocampus is 5% of normal, then you go,
Or maybe I'm trying to remember. It was this is something for over a year ago, and I'm trying to remember. Okay, problem with the memory here. No, it was. I don't know if it was 20% of normal, or it was shrunk by 20%.
I mean, even if it were 20% of normal, let's assume that.
Okay.
I think it's not something you can hang your hat on as far as saying this patient has Alzheimer's or will get Alzheimer's.
Okay.
It's of concern for sure. Might we test that patient someday and see if they have amyloid in their brain? Should they be treated?
Okay.
Certainly. I don't know, but that's where we are with this. That's an evolving issue.
Okay. Okay. Great. Thank you.
Thank you. I apologize for my pronunciation here, but this is the next question. Would you start a patient with memory impairment on cholinesterase inhibitors first or in menamentine first? When would you add other agent, if only to start with the first?
Okay, yeah, I understand. The anticholinesterase drugs, and most commonly used Aricept and Epizil, they're generic now. They're not expensive. They don't have a lot of side effects. They have some GI side effects. You take them at night, once a day. The data on that drug altering the progression of the disease was very weak, but some people feel it might be helpful. I think you should have a low threshold for doing it. It gives the patients and their family a little bit of hope that you're doing something. I don't think you should say it's going to reverse your memory trouble. But as I say, I think there's a very little downside. So in the early stages of dementia, you would use donepezil or one of the others. Memantine, I would reserve for the more moderate to advanced situation where the patient is having some agitation, there's trouble managing. The data on that drug was really, it reduced caregiver burden. So I interpret that to mean it helps calm the patient in some cases. So I wouldn't start that at the beginning. I'd kind of hold back on that. It's sort of, I hate to sound nihilistic, but none of these drugs are very good. But certainly there's no downside, I think, or little downside to putting people on donepezil.
Thank you. The next is, for clarity, can you have detectable amyloid seen on imaging that is considered within normal range, or is all amyloid plaque seen considered as pathologic? Is there a range?
Yeah, of course, there's a range. On that slide I showed, there was a little bit of uptake of the tracer, but I think that there's very clear dividing lines now, imaging wise, that show whether the scan is abnormal or not in terms of amyloid. And the really tricky part is there are people that have amyloid in their brain who do not have dementia, at least not yet. And so it's another test that has to be interpreted.
Thank you. These are all great questions. Are there any other questions? We still have 9 minutes. So again, please feel free to submit them into the chat or to raise your hand. Okay, well, if nothing else, thank you so much for your time today, Dr. Mesher. This was an excellent lecture, as we just got a comment in the chat for.
Okay, great. Thanks for all attending. If you have any further questions, you can get my email, I think, through Maven. Is that right, Erin?
And through the community portal.
Yeah, right. Thank you.
Thank you all.